It's just about 12:30, so I might start this seminar. My name is Ruth Hubbard. Welcome. We are presenting today on frailty in people with chronic kidney disease. So I will speak for a few minutes first, and then Benignus Logan will be telling you about the GOAL trial, and Alyra Shaw will be talking about one of our other funded trials that we have underway at the moment related to a kidney transplantation. But before we start, I would like to begin by acknowledging the traditional owners of the lands on which we meet. This is a virtual meeting, so you will be on the lands of many First Nations communities. I am on the lands of the Yagara and Turrbal people, and I recognise their valuable contributions to Australian and global society. So first slide, please. So I just have a couple of slides to give you an update about the Australian Frailty Network, because many of you won't be familiar with our group. So we were funded by a grant from the Medical Research Futures Fund in 2022, and we held a summit during the first few months of our funding, and agreed our vision for the AFN, which is to deliver a national response to frailty and help all Australians age well. So we agreed our values and our 5 statements of purpose. And I will go through each of those illustrated by a slide. So next slide, please, Benignus. So our first statement of purpose was to establish stakeholder priorities for frailty and ageing research. And for this, we have really focused on the patients and carers who may be impacted by frailty. We now have a very well-established consumer reference group, which comprises more than 130 people across every Australian state and territory. And they are coordinated by Peter, who is our expert consumer engagement coordinator. We also have, as part of our governance structure, a consumer advisory board who really are very closely involved in our planning for research, for engagement, and for policy documents. We have embedded consumers into some of our funded studies, including the FITTEST trial. Just go back a second for me.
Oh, sorry.
That's okay. And the consumers are helping us with our education strategies. We have a dedicated group looking at cancer research and our programs in that domain, and also contributing to the development of the Electronic Frailty Index, which is funded by a partnership grant. So we have consumers currently involved in 10 grant applications and 12 active projects. So next slide, please. In another one of our pillars was to facilitate and conduct high quality research that generates new knowledge. And we have several funded trials underway at the moment. We're trying to become an enabling centre for others who want to undertake research involving frail older people. So the Rainbow Inclusive Aged Care Project, for example, is not a trial that we are leading, but we are providing some methodological support, some consumer engagement strategies, and very involved in that programme of work. So next slide, please. We are also aiming to share evidence-based information about frailty and ageing with the public and with healthcare professionals. And as part of our Centre for Research Excellence, we're developing some online modules for frailty education. They have been co-designed with consumers and should be available within the next few months, definitely early next year. Christiana Ludlow is leading that work. Next slide, please. The sharing of evidence-based information also extends to some of our key papers, which have attracted some media attention, particularly a paper published by David Ward earlier this year showing that frailty trajectories can predict people who develop dementia. That got a lot of publicity in the lay media. And Emily Gordon led a paper last year looking at the impact of delirium and the fact that people with delirium in hospital are 3 times more likely to develop dementia. Next slide, please. Here we have the Frailty Nexus, so our statement of purpose regarding building capacity for multidisciplinary and translational frailty research is being supported by Benignus, who's our next speaker, who runs our Frailty Nexus, which is an online forum, a virtual community of practice for researchers and healthcare professionals with an interest in frailty. So everyone is very welcome to join up to these events and to come along to attend the webinars and to receive our flyers about funding opportunities or job opportunities. Next slide, please. And our last statement of purpose was to enable translation of research into practice. And an exemplar of that is that we were commissioned by the Queensland Health Reform Office to generate consensus statements for the management of frailty in community dwellers. And that work is currently being peer reviewed. Next slide, please. So we started as a very small team a couple of years ago and have now extended to encompass 8 research fellows, 12 professional staff and our well-articulated consumer advisory board. Next slide, please. And we are collaborating with international and national experts in frailty and ageing and a couple of research methodologists that we particularly needed to engage. Last slide, please. So before handing over to Benignus to talk about the research programme, I just wanted to acknowledge our partners and our funders, including Metro South Research Support Scheme, who really started this research journey for me with a project grant that was awarded a couple of years ago. Next slide, please. So this is just articulating the journey that we have undertaken with respect to chronic kidney disease. So the trial that we're focusing on first was an NHMRC targeted call for research into frailty. And this has been undertaken in collaboration with AKTN, the Australian Kidney Trials Network, and this was a cluster randomised control trial that Benignus will tell you all about. We've also had funding from the Metro South Research Support Scheme in projects led by Emily and an ideas grant that Alyra will be talking to you about today. So a couple of housekeeping things that I should have said at the beginning, which are that the meeting's being recorded and we will have questions on the chat. So if you have questions or comments as we go through, feel free to put them on the chat and we'll address those at the end of the presentations. So I'll hand over to Benignus now. Thank you.
Brilliant. Thank you for the opportunity to present today. Most of what I'm presenting today is closely aligned with the PhD I'm just in the process of trying to finalise and submit. So at the outset, I just want to really acknowledge colleagues at the Australian Kidney Trials Network who have been such great collaborators since this began, for me at least since 2020, and I know that Ruth and others have been working on it well before then as well. So also, because a lot of this is part of my PhD, I want to acknowledge Ruth, who's one of my supervisors, as well as Andrea Vercelli and Elaine Pascoe, who are other 2 supervisors, which I've been most grateful for. So before we get into the GOLD trial in more detail and talking about chronic kidney disease and frailty, I just wanted to set the scene by talking a little bit about frailty more generally. So when I think about frailty, I like to think about these photos of my parents, and you can see they're similar age. Indeed, mum's a little bit older. And I think about not just how they looked about the same age, but also in what they were able to do inside and outside their homes for themselves. Regardless of your backgrounds and based purely on a photograph, I think you could all recognise that Dad is more frail than my mother in these pictures. I know that this is quite a superficial example and belies the complexity of frailty and how it is measured, but certainly recognising frailty is very important because people living with frailty are at increased risk of adverse outcomes, including admission to residential aged care, falls, delirium, and the list really goes on. So what can we do to help people like my father who's living with frailty? So shown here are the likely pillars of interventions which can help prevent and reverse frailty to help people live better lives. And excitingly, the Australian Frailty Network has a number of research endeavours underway to try and understand the effectiveness of some of these interventions. I don't have time to go through all of these, but I did want to particularly highlight comprehensive geriatric assessment, given that's been quite relevant to the GOLD trial, as that's the intervention being assessed, and by virtue of that, also some of the PhD I've been undertaking. So I'll just speak a bit about what a CGA is for people who may not be here from a health background and might be joining us from the university. So essentially, it's a review conducted by a specialist geriatrician in either an outpatient clinic or in a hospital ward where an older person has been admitted. So CGA is a multi-dimensional, multidisciplinary process which identifies medical, social and functional needs and then develops an integrated care plan to address those identified needs. So listed here are possible components across a number of domains which individual geriatricians may choose at their discretion to tailor to the person in front of them, but it's very much a person-centred intervention and review. So for some people, some of those components may not be relevant. So expert opinion advocates that a CGA is completed for all frail older people. And there's evidence that in an inpatient setting, a CGA can improve the chances an individual will be alive and living in their own home at 12-month follow-up. And in an outpatient setting, it's been shown to reduce the risk of unplanned hospital admissions. However, there's been a lack of high-quality clinical trials establishing the effectiveness of comprehensive geriatric assessment as an intervention for frail older people and also people living with chronic kidney disease in order to reduce their frailty. It's also unclear whether a CGA has the ability to help people better achieve their goals of care. And so the GOLD trial really has sought to understand that for those frail older people living with chronic kidney disease. So turning to the GOLD trial in a bit more detail, the population we looked at was frail older people living with chronic kidney disease stages 3 through to 5, including those receiving dialysis. The study sites were randomised to the intervention or comparator group on a 1-to-1 allocation, and trial participants at an intervention cluster received a comprehensive geriatric assessment. And the primary outcome measure was the attainment of an individual's goals as measured by goal attainment scaling, which I'll come to in a little bit more detail shortly. So the way I thought I'd structure today's presentation is talk you through the key research output we've had to date and also draw out of those research outputs some of the take-home messages which I think might be useful for attendees to consider and reflect on. So the first research output was our trials design as documented in the study protocol. We've also done a lot of work to improve goal attainment scaling as an outcome measure in research settings. We have now, by analysis of the baseline characteristics of the participants we recruited to the GOLD trial, we now have a good understanding of their frailty and disease stage and also their quality of life. And we also have a good grasp as to the goals of what they prioritise for their care and what's most important to them. The final piece of the puzzle, which I won't be able to talk through today as we're finalising the manuscript and those results are still under embargo at the moment, is whether or not comprehensive geriatric assessment is an effective intervention for this particular population. But hopefully you'll hear more about that in the coming months. So starting with the first research output, which was our study protocol, and that was published in Trials, and that was very much integral to the successful activation, conduct and analysis of the trial. But the key thing I really wanted to kind of draw out from this protocol document was the importance of consumers being involved from the stage of grant writing through to trial design and protocol development. And this ensured the inclusion of patient prioritised outcomes. Consumer input was also important to ensuring all the participant-facing material through to recruitment flyers and also information that was provided through the goal setting process was appropriate and consumer-focused. And their involvement throughout all the stages was really important to ensuring that we had adopted a person-centred approach to the trial's activities and interactions. And all of this, I guess, we found to be quite favourable in our ability to recruit frail older people. Something cool, which we just, Donna, one of the operations managers for AFN, had come across just recently, was that in the updated Spirit guidelines published in BMJ, our protocol was cited as an exemplar of how to promote participant retention and complete follow-up. So I think the key take-home message from this research output is that consumer involvement is important and helps ensure a person-centred focus to the research we're undertaking. The second large piece of work from the trial was really around improving goal attainment scaling as an outcome measure in research settings. So our intent really was to minimise any potential biases in our own trial, given it was our primary outcome measure. But also we wanted to help other researchers in utilising their tool, this tool rather, in their own research, which might be supporting person-centred research. So many of you may not be familiar with goal attainment scaling, and the QR code in the bottom right-hand corner links you to a website on the AFN portal, which talks through the work we've done in this space and also links to the published training material that we've shared with the broader population. But essentially, goal attainment scaling begins by identifying a goal. And for example, it might be to run further. The second step is to define possible future outcomes on a scale of 5 points, where achieving the expected outcome means that someone has met their goal. And the final step is at follow-up to look at the actual achievement that is achieved. So this demonstrates here an example of the populated GAS or goal attainment scaling templates as utilised for the trial. And you can see that participants were able to set between 1 and 5 goals of their choosing. So we did develop a comprehensive training package, and that was developed through review of current literature about goal attainment scaling. It was informed by learning theory principles. We had conversations with researchers who've used the tool in Australia and also overseas. And we piloted it on some research nurses who were using goal attainment scaling as an outcome measure in another trial, which Ruth was leading at the PA hospital. So there's several components to it, including formal classroom teaching. Because of COVID, that was done over Zoom. We had self-directed reflection and reading. We had online demonstration videos, one-on-one simulation and feedback sessions. And we also had hot reviews, which is where the first 5 goal attainment scaling sessions that a research nurse had with a real life participant was sent to myself for a kind of a third-party review to see if there are any issues to amend or refine. So all of this is, like I said, available on the website. And to date, we've had well over 1,000 views of the website and over 800 document downloads. So the key take-home messages from this research output is that for those of you who may be planning to undertake research, you may wish to consider whether goal attainment scaling might be an appropriate outcome measure, particularly if you are seeking to prioritise person-centred research. And secondly, all the material is available online for adoption as needed. So moving on to the next research output, which was a paper we published looking at the baseline characteristics, but in particular, we really drilled down onto frailty and disease stage and looked at quality of life measures in the population we'd recruited. So the study aims were around describing participant baseline characteristics and understanding if there were any relationships between those characteristics and a person's CKD stage and their frailty severity. But before I get into the actual findings, I think it's probably important to define some of the key measures we use because not everyone may be familiar with it. So we measured frailty using the Frailty Index, and that's a tool which was developed by Professor Ken Rockwood, who had also developed the Clinical Frail Scale, which is something probably more people are potentially familiar with given its use in emergency departments across Queensland at least. And basically the Frailty Index looks at the number of deficits a person has in a number of domains, including, medical conditions, mood, medications, social isolation, functioning, and so on and so forth. And it looks at the number of deficits an individual has over the total number of possible deficits which are being assessed for, and that gives an index score. So there has to be at least 30 variables that you're looking at, and Ken Rockwood's group has done a lot of research and publication on what constitutes an adequate number of variables. But essentially, it gives you a score which is between 0, which is a very robust person, through to 1, and on a continuous, so it's a continuous variable. And where there's a cutoff needed for things like our research trial where we're recruiting people, a recognised cutoff is 0.25. So people with a lower cutoff are considered to have not be frail, and those with a higher frailty index are considered to be frail. And whilst you can see the score, I guess, arguably could go to 1, you do find that a frailty index greater than 0.65 is generally not ever seen because it's not really compatible with human survival. So to give some flavour to what this looks like in real life, I applied this to my parents. And starting with my mother, I looked at her and she only had 3 out of a possible 58 deficits that we were using for the GOAL trial. So that gave her a frailty index of 0.05. So not particularly frail, or well, arguably not frail at all. Then I completed it on my father and he had 27 out of 58 possible deficits, which was a score of 0.46, which sets in that severe, very severe degree of frailty. Some of you would be familiar with my aged care assessment. So a number of years ago, it was looked at what the frailty index was for the typical patient being referred for my aged care assessment. And on average, that was found to be sitting just below the cutoff at 0.24. And for those of you familiar with the clinical frail scale, it doesn't quite neatly match with the new versions of the clinical frail scale, but it gives you again some sense of where a CFS level 5 sits and a CFS level 7 sits at 0.27 and 0.43 respectively. So for the GOAL trial, looking at some of the data we had there, we found that the median frailty index was 0.39. So this was a very severely frail group of individuals that we had managed to recruit. The other key thing to talk about is chronic kidney disease, and stage of chronic kidney disease is commonly measured through an estimated glomerular filtration rate, which is a blood test, and normal function in that is greater than 90. So for our trial, we were only looking at people with moderate and severe chronic kidney disease. So in that setting, we considered people with an eGFR between 15 and 60 of having a moderate chronic kidney disease, and then less than 15 was in keeping with severe chronic kidney disease. So again, to give you some context about how this looks in the real world, so there was the ASPRI trial of community dwelling Australians over the age of 70, and they had 16,000 participants, and in that population, the median eGFR was 74. So in our population, albeit it was skewed to obviously only recruit people who had CKD, but we found that the median eGFR for GOAL trial participants was 25. Moving on to the last kind of key measure I wanted to explore in detail was the quality of life. And for that, we looked at the EuroQol 5 dimensions, 5 levels index score. So the EQ5D5L is derived from 5 domains, including mobility, self-care, usual activities, pain, discomfort, and anxiety and depression. So the possible scores are between -0.3 through to 1. People who score 1 or around that denotes that they've got very favourable health. A score of 0 equates to equivalent to death, and a score under 0 equates to being worse than death. So again, for some context, population studies have found that the median, so the mean EQ5D5L index score sits around 0.83 to 0.87. And for our GOAL trial participants, we found that they had a median EQ5D5L index score of 0.83. So that was largely in keeping with what we see in other older Australians, not necessarily with chronic kidney disease. So the quality of life can also look at the visual analog scale, which I guess is probably more intuitive. So on a scale of 0 to 100, 0 being not very happy, through to 100 being very best health imaginable. So for context, older Australians had a mean EQ VAS of 72 to 78, and the median EQ VAS of our population that we looked at in the GOAL trial sat at 60, so less favourable than their peers. So that gives you some sense of the population we were working with. So ultimately, over a 27-month period, we recruited 240 participants. 56% of those were males, and most were either white or European at 83%, and only 3.5% of participants identified as Aboriginal or Torres Strait Islander. The mean age was 77 years, and participants predominantly were community dwellers. 65% resided with someone else and 32% lived alone. The most common causes for an individual's chronic kidney disease are listed there, and it was from diabetes, hypertension, and glomerulonephritis. And we found that 36% of participants were receiving either dialysis, be that hemodialysis or peritoneal dialysis, or were in receipt of a kidney transplant. There was a high burden of comorbid health conditions. So on average, people had 9 comorbid health conditions. And we found that 55% of our participants had 10 or more medications, showing a high degree of polypharmacy. So looking at all the baseline characteristics, what we really wanted to do is looking at those 2 key variables highlighted in purple there. We wanted to understand if there are any associations between the black variables listed there and the key variables of interest being CKD stage and frailty severity. And there's a couple of key findings we'd like to share. So whilst the frailty index was more advanced in people living with severe chronic kidney disease, as you can see there, 0.41 versus 0.38, that wasn't statistically significant, which was a little bit unexpected compared to what we were anticipating when we started doing the analysis. What we did find is that those with more advanced chronic kidney disease had a less favourable quality of life score, both with the index score and the visual analogue scale. Again, that's not a surprise and probably what maybe would be expected, right? But I think the value in this and the following slide is that it's something that hadn't been really articulated in the literature previously, even though it was assumed perhaps to be the case. So I think that was important to have undertaken. And similarly, you can see as the degree of frailty progresses from moderate through to severe to very severe, the quality of life scores have also deteriorated. And again, that was statistically significant. And again, was a finding that isn't well established in the literature, even though it's, I guess, reasonably well assumed that would be the case. So the key take-home messages from this particular research output was that given the findings that the quality of life scores of frail older people living with chronic kidney disease are worse in those with more severe frailty and those with more advanced chronic kidney disease, the recommendation is that clinicians should be aware of that relationship between quality of life and also both frailty and chronic kidney disease. And it's hoped that this will enable them to tailor assessment and management plans to what may best enhance their patients' quality of life, be that through functional gains or symptom relief. So moving on to the final research output I wanted to talk about today. And so the focus here was really to understand, identify and then categorize the goals of this population, and then to determine if there are any associations between their goals and a participant's frailty status, quality of life scores, and also their chronic kidney disease stage. So we know from prior research that older people living in the general population prioritise things like maintaining independence and engaging in social activities. And we know that people living with chronic kidney disease note kidney function and life participation as critically important outcomes. Frail older adults with chronic kidney disease have complex care needs, and their priorities may differ from those assumed by healthcare professionals and providers. So understanding their goals is crucial to delivering person-centred care, which is a pillar of quality healthcare. So to help us undertake this part of the project, we looked at the first key data input was really the goals that participants set. And as I mentioned before, people were invited to set between 1 and 5 SMART goals. And there were no kind of predetermining restrictions or constraints or categories or lists that they were provided with. So they really had open open permission to set a goal about anything. The only real caveat was that it had to be achievable in 3 months, given that was that was the primary outcome measure. And the second key data input was the participants' baseline characteristics, and highlighted there are the key ones we're interested in was frailty, CKD stage, and quality of life. So this was useful input for the quantitative data. So I led a deductive content analysis, and we were aided by a pre-specified matrix as shown there on the slide. So this matrix was developed by a literature review, and then I sense checked it with my peers, so nephrologists and also geriatricians, who were the co-investigators, to sense check it with their clinical experience to see if it was a reasonable starting point. So then we invited the research nurses as they were entering the baseline assessments to input into REDCap codes for each of the participants' goals to one of these categories. To enhance reliability and trustworthiness of the coding, I reviewed all the categorizations as a second coder, and where there was discrepancies between the research nurse and myself, it was escalated to a third coder who had expertise in qualitative research to help resolve those inconsistencies. So as a result of this process, some changes to the categories were deemed necessary to better reflect the goals which had been coded to them. And aside from the 2 modifications marked there on the screen, there was no other changes which were deemed necessary, and we didn't need to add any extra categories. So as I mentioned before, there were 240 trial participants, but only 224 had actually proceeded to set goals for the trial. And in that population, there were 408 goals generated in total, with most participants setting between 1 and 2 goals. So shown here in the first column is all the goals which were set. And then in the second column, it shows us weighting it for each participant to account for those who set, 2 or more goals. So you can see that most frequently participants set their goals in the realm of function and also physical health. So I then completed descriptive accounts for each of these categories to give you some flavour as to what was entailed in each of them. So I'll work through each of that now. So starting with function, which is the most prevalent, there are 172 goals, and a lot of them really focused on mobility, particularly walking distance, duration and frequency, with the rest addressing balance and mobility aids. Additional goals covered other forms of exercise and activities of daily living, including community access, personal tasks, and also domestic duties. In the physical health category, many of the 86 goals are focused on healthy lifestyle factors, particularly weight loss, while others address cardiovascular risk, symptom management, medication use, biochemical markers, healthcare engagement, and also avoiding dialysis. The 82 goals in the social engagement and leisure category covered relationships, socialisation, artistic and hobby pursuits, sports, gardening and travel, and they really just reflect a wide range of personal interests and priorities, which I guess is not terribly surprising, but was pleasing to see. The 58 goals in the psychological health domain primarily focused on sleep, followed by mood and anxiety management, memory improvement, confidence, and overall life satisfaction. And then the 11 goals in the future readiness was really focused on administrative tasks, advanced care planning, and also downsizing in preparation for later life. So as our second aim was with this particular research undertaking, we wanted to see if there were any relationships between a participant's characteristics when comparing the domains that they set their goals in. And we found that there was actually the number and nature of set goals was similar across participant frailty status, quality of life scores, and CKD stage, which suggests that these characteristics didn't influence the priorities of frail older people with chronic kidney disease. So the key take-home messages from this particular research output was, first of all, that the goals frail older people living with chronic kidney disease set was more aligned to the priorities of frail older people rather than those living with chronic kidney disease. Secondly, it's recommended that nephrologists seek to align their care to these patient-identified outcomes. And thirdly, given the commonality of goals between frail older people living with and without CKD, there may be a role for geriatricians to contribute to the management of this group. So thanks for your patience as we worked through those research outputs. And I guess the most, well, maybe not the most interesting, but certainly something that we're very keen to be able to share is the learnings we had from the primary trial paper, which is looking the effectiveness of comprehensive geriatric assessment. And as I said, we aim to disseminate those findings in the coming months. So in closing, I just want to acknowledge the study sites, particularly the participants at each of those sites, as well as the research nurses, nephrologists and geriatricians, because in some instances that's been an undertaking since 2019 and a lot of work over that time, particularly during COVID. Certainly none of this would have been possible without them. And I'm just one small part of a very large team. So a lot of the team are noted there. And I'd also like to acknowledge the broader Australian Kidney Trials Network with the multiple teams within that infrastructure, as well as members of the Consumer Advisory Board. So for those of you interested in learning more about the trial, you're welcome to scan the QR code there, which links to our trial homepage and the publications we've had to date. And as Ruth mentioned at the outset, we have a virtual community of practice for researchers and healthcare professionals with an interest in frailty. The next event is actually at the end of this month, and it's Fred Graham, one of the senior nurses from the Princess Alexandra Hospital, who's also completed his PhD. He's going to be talking about pain as a cause of agitation in older people with delirium and or dementia. So that will be a very practical and interesting conversation we'll have at the end of the month, which everyone is welcome to attend. So with that, I'll hand over and thank you all for your time.
Thank you, Benignus. We'll just get these slides set up. So as Ruth mentioned, my name is Alyra Shaw, and I'll continue with some of the other projects in this chronic kidney disease and frailty space. So my background I'll share at the start is actually as an optometrist, so not directly associated with any of this content of this work. So I'm definitely not a nephrologist or a geriatrician or a biomedical scientist, but I have worked in research for many years, and I'm the project manager of these projects. So I may have a slightly different perspective on some of the projects. I do get excited by sound research design. I enjoy bringing together and coordinating interdisciplinary research teams. And particularly for the ReFIT study, we took the initial grant funding ideas and bringing them to life as an operational research project. So as Ruth mentioned, there's been a number of different funded studies in this program of work, 2 Metro South research studies. One of these, led by Associate Professor Emily Gordon, was frailty and kidney transplantation measurement and mechanism. And this had a few different aspects to it, but it took that frailty index that Benignus mentioned into the context of chronic kidney disease. And one of the main outcomes was finding that it was a useful tool in this setting. It was valid, feasible, and also acceptable in that setting. Another Metro South funded program grant, also led by Emily, was using kidney transplantation to investigate epigenetic markers of frailty. And it extended using the frailty index in people with chronic kidney disease, but also to the transplant setting. Just a moment. There we go. Okay, so the aim of this study was to characterise the change in frailty status in kidney transplant recipients and non-recipients, and looking at the frailty index and also the epigenetics at baseline and follow-up. So the graph is the key to understanding the design of this project. So we have Group A, the transplant recipients, and they have an improvement in frailty after transplantation, while Group B, those that don't receive a transplant, their frailty worsens over the 6 months that the study was conducted. And specifically in terms of epigenetics, the DNA methylation was looked at. So the results for this study are currently being finalised and written up for publication, but the main results were that there was no evidence for an association of DNA methylation with either frailty index or age at baseline or follow-up. And some power calculations were then done, and it was found that we'd nearly need a 10-fold increase in sample size. So this result, like you'll see above there, that the samples, there were 41 baseline samples and 31 follow-up samples. So I guess this is useful information going forward for any further work in this area. But in many ways, this study was a pilot study for the following one, which I'll talk about, the ReFIT study. In terms of research ethics and governance, it really paved the way. In terms of logistics of conducting these types of assessments in the transplantation setting. And also consumers were involved in this study to design the flyers and to make sure everything was being taken into account when recruiting people prior to kidney transplant. So for the remaining time, I'll talk about the ReFIT study, Reversing Frailty Through Transplantation, or the full title is Organ Transplantation as a Model of Reversible Frailty. And so you'll notice the words I've used a couple of times there, reversing and reversible, and that's the key to the design of this study. Having a look at the different groups, which is the key to understanding it. Obviously, many similarities to the epigenetic study that I just mentioned. We've got Group A, the transplant recipients with an improvement in frailty. Group B, those also with kidney failure who did not receive a transplant. And there's also got an extra group, Group C, the older adults. And all of these groups have a similar frailty at baseline, but then different trajectories over the course of the study. And the biomedical markers that I've mentioned that are going to be looked at baseline and also follow-up, these include many different aspects. So endocrine status, metabolome, microbiome, microcirculation, and also tissue integrity. So in this study, we've got participants all with frailty, some frailty due to kidney failure, others with frailty to age. But our hypothesis is that there's the same underlying pathophysiology to the frailty. So what biomediators, which also may serve as biomarkers, are associated with frailty? For the transplant recipients, frailty improves, so what biomediators improve? And for the non-transplant recipients or the older adult groups, as frailty declines, what biomarkers also decline? Just a closer look at the groups involved in this study. So this is conducted all at the Princess Alexandra Hospital, but two sort of distinct groups, those within the kidney transplant service and then the older adults. So the groups A and B, they all have kidney failure, aged over 40 years. And you'll note some important exclusion criteria there. Those who have received a previous transplant in another solid organ, or those with significant comorbidities unlikely to benefit from the transplant. In contrast, the Group C of the older adults, so they're all recruited from the PA outpatient clinics. These people are screened using the clinical frailty scale, which Benignus mentioned, with inclusion criteria of between 2 and 6. In contrast to the other groups, they don't have kidney failure, and they're aged over 65 or over 55 years for Aboriginal and Torres Strait Islander patients, with some specific exclusion criteria noted there on the slide. So the key variables involved in this study, in the centre there, you'll see the Frailty Index score, which is central to all the measures. Also recording demographics and medical history, and particularly to note the kidney function between the different groups. The kidney function data is collected. And down the bottom, we have listing the biomedical tests, which I've mentioned a few times now. So through the blood tests, the metabolome and endocrine status are looked at. For the metabolome, a lot of different metabolites are going to be assessed. Amino acids, oxidative stress markers, vitamins, bile acids, Krebs cycle metabolites, short-chain fatty acids, and then for the endocrine status, the hormone levels at baseline and the change are also measured. The microbiome will be assessed with a stool sample. This probably has been the most logistically difficult aspect of the study with the stool sample, because it's not collected at the same time as the other research assessments. It relies on people posting back their samples. And also it's been difficult, which we acknowledged right at the start, but in the transplant settings. So there's a couple of different scenarios in terms of the transplants. There's the case of a live donor organ, and in this case, the surgery is pre-planned and it's easy to organise getting a stool sample. But the other timing is on a deceased donor organ, and in this case there's very limited time often, and a stool sample cannot always be collected. The other measures are nutrition, so a comprehensive survey of diet nutrition is collected, and microcirculation is collected. This is through quite a novel technique using side stream dark field video microscopy. So it's actually a camera on the end of a probe sublingually, and that takes the images, which then are assessed for flow and also vessel density. So this study began in 2023 and will continue to 2026. So a milestone last week, the recruitment period actually finished. So we've recruited 111 participants, and you'll see the breakdown of the participants in the graph there. 33 for the transplant group, 28 in the non-transplant group, and 50 in the older adults. And the 12-month follow-up assessments have started, and they'll continue until mid next year. So Benignus mentioned the clinical frailty scale and the ReFIT study. These participants, this all data is hot off the press as we finished the baseline assessments last week. And the breakdown for the frailty index, the median, there was 0.22, 0.24 and 0.22 between the groups, which is good because we're aiming for this similar frailty at baseline between all the groups. And you'll note the ages there. So those with the chronic kidney disease in groups A and B are much younger than the older adult group. And in contrast, the goal participants that Benignus mentioned were definitely more frail, with that mean index of 0.39 and older adults there. So where's all this research heading? So the baseline data, which we've just completed, will be, much of this will be analysed by a PhD student, Trent Payne, and he'll be looking at the frailty and whether that's from the age or kidney failure groups, and looking at those biomedical markers of the, so dietary habits and the microbiome and the microcirculation. Once we have the 12-month follow-up data and change data, we can then look at those longitudinal changes in frailty in each group and look at which biomedical markers are associated with the changes in frailty. And looking at the broader picture, so hopefully looking at all these different biomedical markers and are they related to frailty, and can that be then applied to the age associated frailty. And in turn, we could guide some of the effective therapies to help with frailty. And also just mentioning that in terms of the kidney transplantation, assessing frailty, we can look at which patients may benefit mostly from kidney transplant, because not everyone has ideal outcomes after the surgery. And we also see that there's further work in looking at the physical activity interventions. So can some physical activity improve frailty prior to surgery so that there are then better outcomes? So it's exciting times as we head into the final stages of this project, data collection and analysis. A big shout out to all the ReFIT team, which I've got listed there. So steering committee, management committee, all the consumers, the international advisory board. You'll see there's people from a lot of different varied backgrounds, but everyone's been really engaged in this project right from the start. And we look forward to sharing some results with you in a couple of years' time. And I'll pass back to Ruth for any questions that anyone may have.
Thanks so much, Alyra. Thanks, Benignus. I thought those presentations were great, and I knew the content, so I hope other people online have enjoyed them. There are a couple of comments on the chat just about the transplant group, and there's one question about is there an age cutoff to be on the kidney transplant waiting list? I don't know if any of our nephrology colleagues are online, but the average age of the people on in our study in the younger age group, remind us about that, Alyra.
So that is about 58. There is quite a range there, probably I'd say 40 to late 70s in that group. I'm not sure if there's an actual kidney, like a cutoff in terms of age. I'm sure there's a lot of different factors that go into being on that waiting list. And
okay, so Mark Wallace has clarified that there's no specific age for not being transplanted. Okay, thank you, Mark. Any other questions or comments on the chat? Or was there anything else you wanted to add? You might want to reflect on your experiences of doing a PhD, Benignus, in combination with clinical practice. A few thank yous on the chat.
It was, it's funny because a lot of the work for this PhD really was in 2020 and 2021. They were kind of the peak periods of I guess stress and work, and since then it's been a lot more manageable with the clinical work, and I guess fortunately through 2020 there wasn't much of a social life because everyone was locked up indoors. So I got quite lucky with the timing, but I also found it valuable having a broader infrastructure to tap into at that stage, AKTN, and now with AFN as well, so that made life a lot more enjoyable, which I'm grateful for.
Good. And I just want to reiterate about the GOAL trial, about the nature of the patients that we managed to recruit for that. It really is a tribute to AKTN. We had 15 different recruiting centres around different states and territories, and managed to get 240 participants who were really unexpectedly frail. You know, I thought they were going to be at the borderline of 0.25. I can picture people, you see, older people in terms of those scores, and you know, they really were quite a frail cohort that we recruited. So even those the baseline data about that group is really valuable findings in terms of their goals of care and their quality of life. So quite a unique population we tapped into. Okay, so just lots of lovely feedback for you both about the presentations, but no challenging questions, nothing that we will have to address. So I think we might draw this to a close. Oh, Julie's asking, the younger adults are as frail as the older adults. Would there be any funding to provide younger adults access to geriatrician assessment? Well, this is something that we're thinking about in terms of, we'll have to see what the result of the trial is in terms of whether geriatricians make a big difference, but we do know that there are interventions that can be done to reduce frailty levels. We don't actually reverse frailty totally, but we can reduce it through those pillars of management that Benignus showed in one of his beautifully formatted slides about in relation to exercise and optimization of nutrition, making sure you're not on any harmful medication, and social engagement. So those are the sort of pillars we conceptualize for frailty management. And I think that frailty associated with chronic disease, there may be avenues to explore management through similar a similar lens with the multifactorial approach. Was there anything you wanted to add in relation to that, Benignus?
No, I think it was interesting through the peer review process for some of the publications. Yes, some of the peer reviewers were saying, oh, well, why can't geriatricians be involved? Why is this only for people over 65? So I guess there's a bit of a sense that it might be beneficial to have that holistic care for people who are younger as well. Yeah. So Dad had passed away by the time of me doing the FI, so it was based on like best guess, do you know what I mean? And Mum's pretty relaxed about it. That's the least of her worries of what I've asked her to do before. So yeah, I mean, we all knew Dad was frail and we all knew Mum wasn't. So it was just an exercise. But yeah, Dad, I didn't actually do it on because he'd passed away. But we could make a pretty good guess of it, knowing all the ins out of his life and medical conditions. So yeah.
Frailty physician, that's what some geriatricians are, Kira, that's what I'd say. Okay.
Thanks all.
Thank you so much, everyone. Bye-bye for now.
Thanks.